Okay, good morning, everybody. Did you want to start us off,
Yes,
Nikki, or me?
I'm going to go ahead and start us. Hi, my name is Nikki. I am with MPHI. I oversee the Southeast Michigan Alliance for Addiction-Free Communities Coalition, also called CMAC. And today's webinar is part one of two discussions coordinated so that we can learn more about the proposed behavioral health reform legislations and allow an opportunity to ask pertinent questions from those directly working in the healthcare industry. Today, we will hear from Representative Mary Whiteford. In October the 4th, we will hear from Senator Mike Shirkey, and we hope you can join us. Please note that registration is full for both events. However, we have been given permission to record today's session and will forward the event to those who are unable to attend today. And thank you to all of you who are able to submit questions prior to the event. We appreciate your time and forethought, and we hope that we can get to many of those questions today. If you have additional questions as we go along, feel free to add them in the Q&A function at the bottom of your screen. And please use the chat feature if you are experiencing technical difficulties on your end. And finally, we are very grateful to welcome Dustin Walsh, Senior Healthcare Reporter at Crain, to assist in leading these two discussions. Since we have limited time, I'm happy to first welcome Representative Whiteford to share her plans, and then Dustin will walk us through the questions portion of the event. Representative Whiteford, thanks so much for your time today, and we truly appreciate the opportunity to hear from you, and the floor is yours.
Yeah, thank you, and thanks for inviting me. I want to start out with my why. I grew up with an uncle who's currently 70 years old, but he was born with disabilities. And I saw this guy who ended up with his mother. Every family's complicated, right? But his mother had psychiatric issues and was his primary caregiver. When she passed when he was 60 years old, he ended up in an adult foster care that had an art program. So this man who was nonverbal, barely made eye contact, shuffled when he walked, people looked at him and they wouldn't understand who he was, but he was an amazing artist. So in the right environment with caring people, he's able to live his best life. And that's why I put on here, putting people over politics. There are so many politics with this system, and it's been very running under the wire. It's $3.5 billion just for our public behavioral health system. And what I did was put my team together, and I've worked on this for over 6 years. I was on my CMH board before I was elected, and I was blown away. Didn't realize 99% of people don't understand the system, and it's very complicated. So I put my team to work on this, like I said, for years, and we came up with this proposal. And so I'd like to run through it. And I just want to refresh everybody's minds or reinforce the fact this is a legislative process. The bill that I introduced was actually the 5th version, and that was going through a ton of stakeholders beforehand, CMHs, advocates, providers. And so we had to start with something. So we introduced it, and there's wiggle room. I'm working hard to make sure I have the best bill possible to present to my Health Policy Committee chair in the committee, and then the House of Representatives. It is bipartisan. As many of you can see, we have 2 Democrats, 3 Republicans, bipartisan co-sponsorships. So everybody understands that this is an important issue, and there's a way to streamline it. And that's what this does. Next slide, please. Okay, so this system redesign overview. We've got this mental health code. It's over 100 pages. I've read every single word of it, just trying to understand what the point was. And many people realize that when individuals came out of the psych hospitals back in the 70s, 80s, 90s, there was a big exodus more into the 80s. Individuals came out of these state psych hospitals and into their communities. And I read one of those first letters, I think it was 1990, said, okay, CMHs, there's a population out there. Here's the funding based on your population, because our CMH system is basically a mini health plan. It's based on the population and the number of people on Medicaid. Even my Allegan CMH, they're getting more money now because more people are on Medicaid, even though they're not serving more people. So that's basically the bottom line with this. So that's the point of our community mental health system. And I knocked on doors in my community. It's neighbors helping neighbors. providers, CMH board people working for the CMHs. And I think that's really important. And so my overview or my redesign, the crux of this is that we're maintaining neighbors helping neighbors. So this bottom level, but I've found through my research, there's a lot of streamlining we can do in the middle. But even me, I can't figure out how much is spent on every detail. And I'm a legislator. How does the public know? How does stakeholders know? There's increased transparency. We have our CMH boards, we have the commissioners involved, but what about from the top down, from the point that the money comes into our state to where it gets to our CMHs? And that's where we're adding increased transparency on funding, access, and quality of behavioral health and developmental disability services. So I'll just say IDD services, regardless of insurance status or the ability to pay. It boosts accountability. So I've written in my bill that the streamlined process can be taken over by the department, or they can contract with a not-for-profit administrative service organization. And part of me wants to make it administrative accountability organization because it does add that accountability side of it, so it's transparent. But public oversight is really important. It protects the most vulnerable. This establishes the inherent risk profile of this population does not lend itself to normal health insurance. We have individuals out there that CMHs are paying over $200,000 a year to help them have their best life. You can't put this into managed care. So I completely disagree with the Senate proposal and the 298 proposals. This is not that at all. This utilizes a self-insured managed fee-for-service delivery system through a contracted single ASO, Administrative Services Organization. What does that mean? Okay, right now, CMHs are mini health plans, PIHPs, which is the middle level, prepaid inpatient health plans, there's 10 in our state. And then, so each level is supposed to bear risk, but ultimately the state bears complete risk. So why not cut out all that middle risk bearing, which is incredibly expensive, and just have the state pay for services? So what this does, it eliminates unnecessary and costly managed care administrative structures. And we'll talk about that on the next page. Next, please. So our current system, which is kind of what I was just talking about, you've got the department, mild to moderate is over in health plans or fee for service. 20% of all of our Medicaid population is fee for service. What does that mean? The department pays the bills directly. It doesn't go through any health plan. And then if somebody needs additional services who are in the mild to moderate category, the fee for service goes and pays the service providers. Over on the other side, which is our CMH system, so it's severe and specialty behavioral health care, then the money flows down to 10 prepaid inpatient health plans. The goal of PIHPs is to have oversight on the 46 CMHs. And that's because the department wanted to not have oversight on all 46, from what I understand, but they wanted the prepaid inpatient health plans who will then have oversight on their 46 CMHs. But then that gets complicated, like many know. We've got the big three, I call them. We've got Wayne, Macomb, and Oakland County, which their CEOs are both the CEO of the CMH and the PIHP. Now that's a huge conflict. And so we have these three, and then we've got the multi-county PIHPs. I've got 7 counties in my PIHP. So we're supposed to have Kent County, which is 50% of our region, try to work with our really, really low population rural areas. Another conflict. It's just strife with conflict. So then you have the CMHs. Many provide services, many don't. A lot of our big three, I mean, Macomb County, they do provide about, I heard about 40% is where they hire people to provide the services. But the rest are contract managers. They contract out to an agency or benefit manager. I'll give an example. So Oakland County, they'll contract to MORC. Well, that next level service providers, MORC also has contracts. So then you've got the state with a contract with the PIHP, with the CMH, with MORC, with other agencies, until you finally get the care to the person. And we wonder why there's an issue with direct care worker reimbursement and payment. The people who are most impactful for people's lives are the ones who are one-on-one with them. And we are completely disrespecting them in our system that is current. My proposed system has the department They can do the administration of this, or they can have a layer of an administrative service organization. And I've checked in other states. This is not a complete replication of any other state, but we just pulled different things. And I talked to all these other states as well and how they did it. So you have the administrative service organization will not be a direct care provider. I want to make that very clear. They administer things. They provide oversight, and we'll talk about that more. So the ASO down to the 46 CMHs. Then if you've got the agency or benefit manager like MORC, or this down to the service providers. Otherwise the CMH, like I've been all over the state. I was up in Houghton. They are 100% caregiving. But then we have Kent County, Oakland County, Wayne County are complete contract managers. They don't provide the services. Next page. Okay, so what I was talking about earlier is how do we have transparency on this entire system? And that's my proposition, my proposal here. There's a Consumer Oversight Committee, gives representation to persons served. The people who are on this and appointed to this, we put on here now, we have at least 2 persons served or their family to be on the committee, but we can have more. I've been asked to have at least 51%. And so they would have oversight and input on what's going on between the department and the ASO. Then we have financial oversight. The crux of this, and I go back to the direct care worker payments, is that we need to have this system sustainable. So that means there's money in there to be able to pay people to do the job, and they can go home and feed their kids. Healthcare isn't free. So we have to make sure that these rates are set properly so that we can actually provide the really important care, support, services, housing, whatever we need to do. And so this part is the rate setting. And like I said, that's really, really important. And if there's difficulties figuring out those rates, there's legislative recourse. Now, something that's going on now, I'm chair of the Health and Human Services budget. It's about 30.6 billion now. But in my budget language is setting up hospital rates. So we've been working on rate setting. What's the right rate that hospitals should be reimbursed for different behavioral health services? Right now, it's one rate. And guys, that's the reason why we don't have as many psych beds across the state. That rate of reimbursement, they can't even pay the nurses to take care of people. So we need to make sure that we are setting proper rates so we can keep these doors open. And then something else that's going on right now, and many people know the CCBHC, so that's community behavioral health clinics. So one-stop shop, physical health, behavioral health care, and that's federal money coming down. There's a lot of rate setting going on right now to make sure those rates are proper so that people can keep their doors open and pay employees and people can feed their families. So financial oversight will have a team, a committee that sees what's going on with this. And then quality oversight. I've heard from psychologists and other professionals that one county can have a treatment for schizophrenia with a prescription. Another one found best practices is a special therapy as well. There's a huge difference going from county to county. And so what I want is for clinical guidance and professionals to be able to set up standards, statewide standards, not mandates. I'm not going to write this into the law, but standards that Michigan has for how we treat different things. And I would like to see Michigan as the top in the country for how we take care of this vulnerable or support this vulnerable population. And so that would be the Quality Oversight Committee setting standards. Next slide. The role of the ASO. So like I said before, I'll say it a third time. The department can do this. This is just administration and keeping paperwork. But the one thing is management provides one point of intensive care management to attend to all facets of a consumer's needs. What this means is, I mean, we have housing money coming through for HUD. We've got other silos, other departments across the state that we can have. This is the one point to make sure that the funds get down to people as they need it. And that's really important. Data analysis. I mean, it's taxpayer money, guys. And it's also our population that's most vulnerable. We need to have checks and balances. We have to have data analytics. We have to assist with, this will help with fee schedules, payments, data collection. And we want to optimize care coordination, and we need quality tracking on processes and outcomes. And that is really, really important. Like I said, provider support. If you talk to providers out there, and I know quite a few of you guys are, it's difficult going county to county. Rates are different. You've got different guidelines. What this would do is have more of a flow through so providers who are the direct care workers get paid properly. Next page. Expected cost savings. I had my fiscal team put this together, and this is where, it's really not transparent. It's hard to figure out what exactly we're spending on administration. All I know is if you're talking about the people taking care of our population, they're not getting paid enough, right? Otherwise, I wouldn't be dealing with this direct care worker issue. So let's, this system must be right-sized. So I am proposing at least 100 million according to my fiscal team, but up to $300 million per year. Why? Because we are considered a health plan, and there's a lot of work with that. We also pay Milliman at least $25 million a year to set up rates. And as I've traveled across the states and talked to CMHs and people who are working on all this paperwork, there is so much time and energy, and I say paperwork again, even though it's on a computer, to prove out the numbers that Milliman is claiming that each area should be getting. I talked to the director about this previously, and I said, what do you think about Milliman? And they're like, well, we can have, they can put together a proposal on rates, and I'll go back. So the director will go back and say, hey, did you think about this issue? And they'll be like, oh no, totally different numbers. That's a problem. It is murky. It is difficult to stay on top of it. And I would say that's the number one thing that everybody across the state agrees with me is we have to get the actuaries out of here. We have to streamline this. And we don't need to be health plans, but the crux is how do we make sure that there's the funds available to do this? And I'm going to go back to the rate setting. There's a way to set up rates for an individual like my uncle. He's not going to get better. He's going to need to be taking care of certain supports. So we know what that amount is. So that's part of the rate setting. If we make sure the rates are set for each individual in care, and then people can keep their doors open and take care of them. And the other thing that is important is my plan covers all mild to moderate too. So that's a huge issue of support that I've heard across the state. We have to stop taking a person and divide them into two. If they're mild to moderate, they go through their health plan. And I mean, you have to admit there's limits that health plans put on, especially people. I just see it over and over again. And then by the time, you could have somebody who needed care, needed supports, when they were mild to moderate, didn't get them, they end up self-medicating, then they're in their substance use disorder, or they keep getting worse. So if we can help people more at the beginning, that's so important. And I think it's important to state that an individual has choice. They can stay with their health plan if that works for them, or they can go to a local CCBHC or clinic, or I know in my county, they're building a clinic where you can, anybody can walk through the doors and get help. Next page. Advantages. So increased cost savings leads to increased care for those served. I'm going to give you an example. When I actually represented my county on my PIHP, and many people have heard about it, the LRE, kind of the problem child. But I was just talking about how we've got a city and then we've got rural areas and they're trying to get along. Well, a company came in and said, okay, to get along, this is what you need to do. And when we costed it out, it was an additional $1.2 million of administrative costs. And I said, well, where's that money coming from? Well, it's coming from the current Medicaid money flowing through. And I'm like, so it's taking away from services that are money that is supposed to provide services for people. And they're like, well, yeah, that's what we do. I'm like, that's not right. So significant administrative cost savings leads to increased care for those served. We have to stop being a society of no, because we can't afford it, because the money's there. Greater transparency, public oversight, accountability. You don't have to navigate health plan laws, which everybody's doing right now. And then the CMHSPs are the focal point for the provision and delivery of these services. Access, efficiencies gained lead to increases in services received. Like I said, if there's more funds, then we can do this. And then we can serve a larger population. Personally, I've seen this $3.5 million start at about billion and go up every year. I mean, I would like to see more money spent in this area because more people are getting served, more people are getting saved. We're saving families here, individuals in our society. Quality. If we have this early intervention, there's fewer emergency room visits. There's fewer psych hospital admissions, increase in preventive service screenings and visits. Early access, early intervention is key to this. Next page. So I did a lot of talking. You can tell I'm very passionate about this. I just hear from people in their homes and families who are struggling with the current system. People can say, hey, everything's great, but we're faced with a KB lawsuit. The CMHs have left a lot of people out of there. That KB lawsuit said that kids who qualified for services didn't get them because the CMHs said that they weren't able to do it. And then they go into adulthood, and this 3-year-old who could have gotten help with autism when he was younger is now a 16-year-old, 180, 200-pound kid who hurts his mom because he didn't learn those checks and balances that early intervention would have provided to him. So I hope that this will make a difference. I hope it makes sense. And Dustin, off to you.
Hi, thank you. Yeah, so I'm going to go ahead and just throw questions. Most of these questions have come from the audience. I'm newer to healthcare reporting, so you know more than I do at this point. So I'm going to kind of focus on their questions because they're the experts in this field. I think the thing that stood out to me is sort of this reduction of Michigan's 10 PIHPs to 1 ASO. Even if we have the ASO organization, we look nationwide, like Washington State, for instance, has 10 ASOs. How is 1 ASO going to basically be able to provide all of the necessary, what it needs to do for the entire state? I understand, because there are, as you mentioned, there are so many regional differences and differences in care and cost. How is 1 ASO going to basically be able to funnel all that work and make sense of it?
Yeah, I appreciate that. And that's the biggest thing I've heard across the state of concern. And so I'm just taking input on how best to do that. I've had people say, should we have a rural ASO and an urban ASO because they're so different? Or do we have 1 ASO with specialty regions, departments in it to help? It's not going to have the same role as a PIHP. A PIHP is a prepaid inpatient health plan, but it also has a lot of responsibilities. And we're actually putting the responsibilities on the CMH. And the ASO is just the flow through that has the data. You have to remember, so we've got the Michigan State Police. Their job is to enforce the laws of the state. So each department's role is to enforce the laws. The Department of Health and Human Services' job is to enforce the laws of our state. And because there's so many different layers, it's been nearly impossible for those laws to be enforced. So what we're going to do is have the department have a bigger role in this, and they're going to get their data up there. So like I said, the ASO is not going to have the same role as the PIHP, but that exact setup has some flexibility. So anybody has specific recommendations, get them over to me.
Okay. And I'm going to go back to that comment right there, but I do want to kind of understand the ASO a little better. Who do we do? Maybe it's too early in the process, but do we know who is going to appoint the director or a top executive at an ASO? And how does that organizational structure work?
So what happens currently with any contract? I came up with the bill idea for the Michigan Crisis and Access Line. I put together the draft for the bill, got it signed into law, and it's the department's responsibility then to enforce the law and put it out for bid. And then when those bids come through, then it's their responsibility to make sure that that is set up properly. And for me, it's important to make sure it's not for profit, and that they're not providing direct services. And that specifically will be written into law. But we're really streamlining things so the department can do their number one responsibility, and that's enforce the law. But like I said, they would put it out for bid.
Okay. And then I want to go back to sort of the PIHP, since we're basically eliminating them. I mean, they do a lot of work, right? They review medical necessity, recipient rights, complaints. If you eliminate that, does that work then go to the ASO? Does that go to the CMHs?
So the CMH has all those responsibilities as well.
Yeah.
So the CMH has the responsibilities, and then the PIHP has the responsibilities, and then the department has the responsibilities. Why don't we just have the CMH have those responsibilities?
So is the argument that it's duplicative work?
Absolutely.
Okay. And then I wanted to go back to, is there any concern, obviously you just mentioned it's duplicative work, but they do provide quality oversight. Do you think in this system that because you are basically condensing services into smaller organizations, theoretically, that quality could slip in this case?
So I beg to differ on that issue. I don't think the PIHPs improve quality. I think the people who are part of the CMH, that's their responsibility with oversight from the department. I think it's completely duplicative.
Okay, and now I want to kind of get into the funding model just a touch. Obviously, if you talk to anyone in the mental health space, they're going to say, what's your biggest problem? The number one answer is always funding, money, money, money. We're dealing with a labor crisis in across the entire healthcare sector, if not every sector. And you had sort of pinpointed where you think estimates that you think cost savings can come from. Won't those cost savings essentially be eaten up by a different administrative structure? Because again, you're eliminating some duplicative things, but you're adding structure elsewhere.
Yeah, that's a good point. So PIHPs, they range from 8%. I actually had one company say the PIHP administrative rate could be up to 14%, but say it's 8 to 10%. Other states that do this, that have proven it out, have it about 3 to 4%. What's really interesting is that I'm just going to give an example of the state of Connecticut. They started with their behavioral health system, found that it really did streamline things. And I've had stakeholders who are actually out in Connecticut talking to them and found it was better. They actually eliminated all Medicaid health plans completely. Our Michigan Medicaid health plans are the most expensive in the nation. And that's like, it's public knowledge, but they won't talk about it. They're 18%. And when I talk to them about it, they try to explain why that's not true. I don't want health plans to be in charge of this. I also believe that if we stop the duplication and then we stop all the extra needs that are part of being one health plan and then the PIHP is another health plan, we're removing a lot of unnecessary bureaucracy. And then that frees up that team to be able to take care of people. And I was out, like I said, I was in Houghton, I was in Traverse City. I mean, it's the same issue. They're spending so much of their budget doing paperwork and they can't figure out how to get out from under that. Well, I have a plan. This is a way to do it. If we have it streamlined, fee for service, stop considering us health plans, set up those rates properly, then we're getting rid of a lot of stuff that we shouldn't be prioritizing. We should be prioritizing the people served.
And I want to now jump into the issue of the mild to moderate cases. So much of the funding model has been reserved for severe cases of mental illness. Obviously, I think everyone can agree that getting mild to moderate cases involved is critically important, especially long-term costs. But it does put more stress on the system to bring them into the fold. Are we going to have to do a provider push? I mean, there's going to have to be a greater need for providers under a system where people appropriately are going to get more care.
Yeah, so yeah, I'm chair of the Health and Human Services budget. I've had it for 3 years now. I understand that we do things by case rate. We fund things on case rate. If cases are up, we work it out. I mean, that's just what we do. So whoever's in there, we're going to make sure that they're getting the services they need. When you're talking about professionals, that's been a huge priority for me for the past 3 years. Number one, you need it on every level. So psychiatrists, what we're doing with psychiatrists is something called a MyDocs program. And for about $1 million a doctor, we're able to get them through their residency and into psychiatry. We've got a lot more psychiatrists being focused, getting these kind of like scholarships basically, but paying for their education. So they go into high need areas and high need rural areas. We also have mid-level providers. So one thing that is in my final budget that's before the governor, I think today, is $1.5 million to get 35 psychiatric nurse practitioners through Wayne State. I've worked on that for the past couple of years. And believe it or not, because everybody's talking about psychiatric needs, behavioral health needs, it's becoming the cool profession. More and more people are going into this career. When we talk about autism, A big thing when we started having autism coverage, for example, is that there weren't enough ABA providers. Well, it became the career where people could get a job. So now there's over 1,000 ABA certified professionals in our state and rising all the time. So if we look at it from all different perspectives, number one, help getting through education. Number two, helps so that they can get paid. Why would anybody go into a career if they're not going to get paid so that they can pay off their loans, feed their kids? They'll go to other states where they're paid better. And so healthcare isn't free. I go back to that. Nobody can do this for free unless, they're trust fund babies, right? So let's make sure that the system is sustainable and those rates are set up properly. So I think along the entire continuum, that's how we're going to get more providers in this field. And I know the department has some ideas as well in response to the KB lawsuit to get more pediatric professionals into this field. So it's all of the above, and you're asking the right person, because I white papered our whole state's response to behavioral health needs, because there's not one magic pill, one thing that we can do to help our state get better. But all of these things together should really help. And another thing that's happened, there's two things. So it's the perfect time. We've got a huge expansion of these community behavioral health clinics. We also have health homes for individuals with severe mental illness, SUD health homes. So that's like a one-stop shop working CMH and the CCBHC to provide our CMH, and a federally qualified health clinic to make sure that all of an individual's needs are met. This was proven out in Northern Michigan. They had 100 individuals with severe mental illness, and they did this model as a health home. Their behavioral health costs stayed the same, but because they were getting help with their health earlier, their health costs went way down, proved out in 1 year. So I funded a massive expansion of that as well. So we're at a perfect time for this. Not only are we setting up rates properly with that boilerplate I put in there to get psych hospital rates, CCBHC setting up rates, we got health homes, all these things are coming together for a perfect storm that we can actually get it done now. We couldn't have done this a few years ago, but I think we could do that now.
Okay. And you mentioned, the fee-for-service sort of based reimbursement model. An attendee wanted to know why, if you could explain sort of why choose that versus the value-based care model.
So if you think of value-based, which I assume that person's assuming is how we're doing things right now.
I do not know.
Yeah, I'm not sure. I mean, the way we have things now that CMHs get the funds to, run take care of their population, that's based on the number of people on Medicaid. It's not based on the people who are served. So if we actually focus on the individuals being served, one county may have more people in need, others may have less, but at least they're getting funds based on the people that they're taking care of. And there's a way to make sure that it's not like nickel and diming. Like our current fee for service for Medicaid, the department pays like for each blood test, each visit, it just goes down one by one. But there's a way to set the rates that we can manage all their care at once. And then the CMH can go back if there's things that need to be right-sized. But that setting up those fees properly is a very, very important part of this.
And I think a broader question, I have some more specifics, but I kind of want to get into a broader question of, obviously you sort of pointed to Connecticut, but there are different models. Wisconsin has the, SDS model. There are different models out there. Why choose this model versus maybe a different one? Obviously the one we have now may not be appropriate, but what is sort of the impetus for this model particularly?
Yeah. So I have a team, I say I'm not that smart. I don't know the mental health code. I mean, I haven't lived and breathed this for 20, 30 years, but I have a core team of individuals who have been a part of this. And when we talked about this, they said, look, this is what we thought it should be for the past 10, 20 years. So we just studied all the different states, figured out how best we could do this. And this is where we landed. We got to make a decision. And so we felt like this was the best, but remember, this is the legislative process. That's why I'm here listening to you guys. This is why I've been traveling around the state, listening to all types of stakeholders, because, you've got the people served, you've got the providers of care, you've got the advocacy groups, you've got the CMHs, you've got the hospital systems. Who else? I mean, you've got all these different systems that I've been taking, just listening. I've got a whole book of notes. And that's why I'm here today.
And then another question is sort of on the medical loss ratio. So if Michigan Medicaid health plans have a medical loss ratio of 79%, so is this legislation going to be able to ensure that those healthcare dollars more appropriately get integrated in, even though they can't do it under the current system?
That's a good point. So I don't touch the Medicaid health plans with this. I'm just saying, I don't think that's the right, I don't think going to the Senate plan is the way to go. I don't think the health plan should be taking over this space. I think the state should take full risk. Years ago, it was thought that the state didn't want to take risk, that they wanted health plans to take full risk on things, and just to give taxpayers certainty. Well, I think we've proven out that it's okay for the state to take this risk and pay, make sure that the money follows the people and not follow all these extra laws that create health plans and risk and actuaries. And we've tried that. So I think it's time that we just start streamlining this process.
Sure. And this person, another attendee, talked about sort of streamlining the CMH deal. They deal with 13 CMHs. It says each one has their own paperwork. Even though it's the same paperwork, it just eats up more administrative costs. Is there a way that's going to streamline that aspect of it? Because, are we just going to completely leave them to as they are?
No, so perfect question. Actually, I meant to bring this up earlier, is that we've got the Michigan Crisis and Access Line. The department took this bill and they had the foresight, these individuals who are rock stars, to build into that request for proposals a CRM. So a part of that to have an IT hub for all public behavioral health. And what that means is through this process, we're going to have standard contracts, standard, what are all the different forms that are records, record keeping, all these things, audits will be streamlined to one thing. I put into my budget language last year and this year to make sure that the department sets up a standard audit, standard credentialing, and then that'll all go through the Michigan Crisis and Access Line. So once again, it's the perfect time. Besides the health homes, CCBHCs, we've got the MyCal going live, and they're working out all the kinks. Right now, they're in Oakland County and the UP, working out the kinks because those are the pilot areas, but that's where our IT hub is going to be. We've got the MyHIN network, which is medical records, with massive investments for the past years, so that we have a hub and spoke model for all electronic medical records. And I think they just worked out how an individual can grant access to their provider, to their medical records, because privacy is really important. But like I said, it's a perfect storm for all these things to come in. There's going to be so much savings for every CMH because we're having a common thing that the state's investing in.
So who's gonna have oversight over that model? Is that the single ASO is going to sort of ensure proper funding is being spent, ensure that that the technology integration is pushed down? I mean, is that where the ASO lies in this?
So the ASO has to listen to our department. The department is the one who's enforcing the laws. The department has to have oversight on this. They're going to crunch things and then answer to the department on all these things. Because like I said, like the Michigan State Police, the department's role is to enforce the law. And this allows them to actually do it in one hub, one ASO, or two, or whatever the final decision is, so that all that data comes in. I asked the department, I'm like, would it be better if you added more staff to do this role? Or is it better, what does hiring more state employees mean? You've got more civil workers. You hire somebody, it's much harder to let them go. But if you've got a nimble ASO, so a not-for-profit that's doing this role, I think there can, with the department having oversight on it, I think it really empowers them. But I did ask them, is it better for you guys to beef up on your staff or have a contract with a company that's going to do this where you have oversight? And they're like, actually, we're a lot more nimble if we do it like this. Even like MPHI, who's hosting this today, they're nimble. They're able to do a lot of things that the department isn't able to do.
Okay. Where does block grant funding come in here? Because block grants are very, they're used widely, especially to fund, substance abuse programs, adolescent programs. Do those get impacted in this model at all?
No. And so we do know about some tweaks we have to make to the bill to allow for that. but the bottom line, it won't impact it at all. We're still going to get those working with the department and the feds to ensure that. And whatever CMHs are getting locally isn't going to change. You've got some that have millages, they're still going to get their millages. They still have whatever county match they have. All those things stay the same. This covers the Medicaid side of things. It keeps everything else stable.
Right. And kind of circling back to this model again, with Connecticut being an example, Connecticut being a very small state.
Right.
Are there going to be noticeable differences between sort of the typical model they have and our model? Because we have to basically scale it up, 3 times, I believe, at least 3 times, maybe 4 times.
I had a really good conversation with the Kalamazoo CMH director last week, and he's been around forever. Jeff Patton. He's like, you know what? There's companies out there doing it now. We don't have to reinvent the wheel. And I'm really curious. I'm not sure exactly what he was talking about, but there's a way to do this. And many of our directors are already saying, yeah, we could do this. I mean, one director said, he's the PIHP and the CMH director. Well, it's FTEs. So if you have somebody doing this role, you don't have to have somebody else doing it, and because of that duplication. So yes, the Connecticut model is different. Even Jeff Patton said, you should be looking at this other state, which is a little more aligned with the makeup of Michigan. And so we're working on that. But this is not a complete duplication. We really tried to make this Michigan oriented on our vast state with so many different needs. And I think the best way to do this is that we're strengthening our locals and their ability to take care of the people that they need to. Here's an example. I'm not calling out any counties because of course I'm going to hear all the bad stories, but this particular one, they normally get, here, even better story. So here's a dad. He's got his daughter who has Down syndrome, was in the ISD system, getting supports that way. And then aged out of that, went into the CMH system, and he has to go back every year. And he spends 2 hours with a case manager. And he ends it, and this is what he told me. He ends it by saying, my daughter is a 3-year-old. She will always be a 3-year-old. And they still had services decreased. When we have each CMH is their own managed care plan, and if they have somebody who's more costly, they're going to put the squeeze on somebody else. So let's just make sure that the funding follows the person. And I don't want to be blasé saying that the money follows the person, but if you focus on the fact that here's a person, here's the supports they need, what does it cost to provide those supports? And then that's the money following the person and getting rid of all the bureaucracy in between.
I want to go to the sort of the cost savings model here. What methods did you use to I mean, is it sort of back of math cost savings, or do you think that those numbers are going to be easily foreseen? And then if they are foreseen and we do achieve them, where I mean, is it just dump it back into the system, or is it going to go in a certain direction?
So savings. I mean, I went on and on with my fiscal team trying to determine what the savings are. And there's something called delegated authorities, like the PIHP to the CMH or vice versa. It's way above my pay grade. But so that's where it's really complicated. But if we just go like percentage to percentage, it's a higher amount. But if, like my fiscal team said, it's probably 120 million in savings, which takes into account the actuaries. But if you think of the amount of paperwork, like I was saying, I was talking to people up in Manistee, and when I was talking about the amount of paperwork she has to do to prove out the actuary numbers and audits, and she's like nodding her head, oh my gosh, you wouldn't believe everything I have to do. And does anybody actually read it? And that's another issue. Are they doing all this because they're supposed to, but it doesn't make a difference. So if we get rid of all that extra stuff, I see that more priority will be on the individuals who need it so bad. And like I said, I chair this budget. It goes up every year. I mean, that's a reality. Whatever cases are, we cover those cases. We're the ultimate, we hold the ultimate responsibility for this as a state. And I mean, that's just how it works, guys. I mean, it's not like one thing. I mean, if you shift it here, we're going to not cover something else. And it works out every year for some reason. And we're able to provide better services, but I think this streamlines it. And I'll stop having people come back to me and say, we need more money, we need more money. Well, another thing we're doing, this will be the second year of doing it, is the locals have to put in GF to draw down federal money. And that was something that they did, I think it was like 12 years ago, I was told, to help in a money crunch. So we're taking away that responsibility so the locals can keep more of their GF and not send it to the state. That gives them a lot more flexibility for prevention. So I think that's an important part of this, that we're really trying to make sure that we're focusing on strengthening our local response. But we also wrote in there network adequacy. So if you've got a CMH that doesn't have SUD services, then the department through the ASO can contract directly with an SUD company. So network adequacy is really important when we're dealing with our kids too. If a CMH isn't able to get the PED services that are necessary, it's network adequacy. So then the department has to take over beyond that. Right now, they're left high and dry. That if the CMH says no, there's no other avenue for support. And then we talk about, I've had this question asked when an individual is having concerns and they need to go through recipient rights. Well, there's recipient rights at the CMH level, the PIHP, the department level. We actually, I think I was looking, there's like 18 positions in recipient rights just in the department. Is it right? And I'd like to get some input on that or feedback. Should the department or should the CMH be recipient rights, or is that the fox guarding the hen house? That somebody feels like they really don't have a conflict-free way to address concerns that they have. So I'd like to hear from people too, if they think that's the right way to go, keep it as is, or have it as a separate, like the children's ombudsman goes through a different department than the child welfare system.
Sure. A attendee brought up an interesting, I think, question based on your kind of your description of the father with Down syndrome. Basically, that was sort of rationing care, where your model is going to increase reimbursement, but put the risk on the state. So how does the state now dictate rationing care and where, because everyone does it. So who's going to make that ultimate decision and how is it going to work?
Yeah, so if we talk about rationing care, I believe in the doctor-patient relationship, just for example. So if my doctor says, Mary, you need a knee replacement, why do I have to go back to the health plans and get all these months of physical therapy when I should have just had that surgery to begin with? So we have to acknowledge the fact that our professionals are there with the person who needs the help, and they need to be able to craft a plan that works for that person. We need to have a baseline set of services that are provided. Some of our counties have flexibility. Like I said, they have a local millage that helps with these things. But are we going to have somebody who says, oh, well, I want to make more money, so I'm going to say this person needs this, and this services because I want to get more money in my county? Then we're demonizing everybody else. I think almost every professional is going to try to do their best to craft the right plan for that individual. And here's a good example outside of this. My husband's in financial investing and stuff. Bernie Madoff, when that happened, all of a sudden he had to take all these ethics classes to make sure that he was ethical. Well, he is ethical, and the crooks are still going to be crooks. Why aren't we just addressing the crooks instead of causing harm or putting all this extra burden on everybody else? And that's one of the things. I actually said this to a health plan. I'm like, I don't think the health plan really adds value to my relationship with the doctor and what I need. And that person's face dropped or their mouth dropped. It's just one of my core beliefs. A professional is going to do their best to craft a plan that's right for that person. And let's go after the bad players. And that's where the department's job is.
Okay, I want to get to, so this is sort of a little bit off topic, but related. If we look at Senator Hertel's, Senate Bill 412, I'm assuming you're familiar.
Just remind me.
It prohibits the MDHS from placing prior authorization on certain medications, particularly those in the mental health space, and it sort of it shifts from sort of the PIHPs to the managed Medicaid plans. And so really it's about whether you support that, ensuring that those do happen. It's sort of separate from this, but it is mildly related because you're talking about the managed Medicaid plans and then the PIHPs.
That's a good point. So back in 2013, we had some bills, I wasn't there at the time, of course, that said that health plans, it said that certain medications could not go through prior authorization. And those are drugs like, for one, psychiatric drugs that only the brand name drug can be given to the individual, that the health plan can't go and make a generic be used. So all of our Medicaid population right now, there's a class of certain classes of drugs that must be paid at the name brand. And the point is, you know, if somebody's on a psych med and the health plan says they should be on something else, they can't change it. If one thing's working, you can't change it because they're a highly vulnerable population. So right now it's already happening that health plans can't touch that class of medication. Hertel's bill brings up another point, you know, what's the value of pre-auth? Pre-auth is in managed care. One thing I always thought about is I have a private health plan, so it's okay for me to have a generic, but somebody who's using the state public behavioral health system or state Medicaid health plans, state taxpayer funded, it has to be the more expensive drug. So it's a complicated issue. What's the right way to do this? And I still struggle with that now. I'm curious where Senator Hertel's bill will go. That's pulling more responsibility away from health plans and making it unpreauthorizable. I know that's not a word, but so that's a complication.
Okay, and then several attendees seem to be very concerned with sort of the scope of the CMH, particularly recipient rights and customer service. They're fearful that the investigations will be biased, and then the outcomes will then not be beneficial to patients. Is there any sort of response to that, or some sort of way to comfort them that this model?
Yeah, tell me that one more time.
Sure. They seem to be concerned that the CMH is going to have basically too much authority over anything to ensure safe outcomes and unbiased outcomes.
Okay. That is a huge struggle for my providers. And thank you for that question. Mm-hmm. You know, you can have really great policy, but the politics are what I have to navigate to get a majority of 110 House members, 38 senators, you know, majority of those, and the governor to sign. I would love for our providers to be able to be the gatekeepers, but our system currently is the CMH is the gatekeeper. I wrote into my bill to have, you know, the network adequacy issue addressed, but I'd love to hear more from providers. So what I'm trying to make sure in this bill plan, while navigating a lot of politics, is that we set up a proper fee schedule. I talked to Bob Sheehan with the CMHs, when they're contract managers, how much money can the CMH keep and how much can flow straight down to providers? And he seemed to say 5% as a contract manager was sufficient. And then we're making sure the money's flowing straight to the providers through the CHAMP system, because we have systems set up for payment. Then you wouldn't have to be paid directly by the CMH. So like I said, it's kind of a political bombshell, but having providers also on the Oversight Council, I think is really important. And I think it's a good segue to making sure that we're addressing how important our providers, our direct care providers are for the individuals that we serve while navigating a lot of politics.
Right, and sort of in that space, because you were talking providers here, a lot of the system you seem to be referencing, it almost sounds like, you know, because of the patient-provider relationship and you think the provider has the best case, is that mean there's going to be reduced cap on spending or not cap on spending in this space? You know, because at the end of the day, this does get very expensive, and you said the budget goes up every year, but is it going to continue to go up?
I don't know. I don't have a crystal ball on if it's going to continue going up. All I know is I hear of the people who are struggling and not getting the help they need. They're not getting that early intervention. We're taking care of people when they're so much worse. I've got the legislation for crisis stabilization units. I don't think anybody should go to an emergency room in a mental health crisis. Right now, our police officers take people either to the emergency room or to jail. That's not an option. 20% of our people in prisons are developmentally disabled. Over half of people in our prisons and jails have mental illness that they're getting treatment for. What are we doing? I mean, this is a societal thing. How are we going to right size the system? Anybody has a better idea than this? Making sure we've got the early access, early intervention, that the money follows the person, that I think we have the CMHs up their game. I was over at the Kalamazoo Psych Hospital. I don't want to be blasé again, but at Kalamazoo Psych Hospital a couple of years ago, out of 150 people there, 40 were waiting to be discharged into the community, waiting for the CMH to grab them, right? And they'd provide the wraparound services that they need. If the CMH knew that they would get more funding, they'd be getting funded based on the people coming in their system, I think they'd be out there. I was talking to somebody in another state who has a system. They actually go, they drive the streets, look under bridges, anything for somebody who may need help, they offer it. Everybody still has individual rights to accept help or not, but they're finding people are coming off the streets and getting wraparound services because they never knew they needed it. So I just think this is an opportunity, like I said, to up everybody's game, to go out there, to help the people earlier than later. I think just doing that with that early intervention over time, things are going to smooth out and we're going to actually do better for the people of our state than what we're doing right now.
Okay. On that note, I want to start wrapping up. I do want to say, because you did ask for sort of, if anyone has recommendations, what is the best way to reach out to you for the audience here?
Yeah, definitely. Reach out to Amanda in my office, but if you email my my state email, it's Mary Whiteford, so my name, at house.mi.gov. So Mary Whiteford at house.mi.gov. And we're just, I call this my listening tour. We just have tons of notes that we're taking, listening to people, finding out what we can do in this legislative process.
Okay, well, I want to thank you for your time today. I hope the audience gained something from this. I know I did. I had some questions there and things I wanted to better understand, and understanding that sometimes there just aren't answers to these questions yet because the process is ongoing.
Yes.
So I really appreciate your time today, Representative Whiteford.
Yeah, thanks.
I'll make sure when they reach out to me, I'll push them to you because I don't know.
Okay, awesome. Thanks, everybody.
All right, thank you. Everyone have a great day.
You too.
Thank you so
Nikki,
much.
is there anything you need to follow up with?
No, I appreciate. Thank you so much, Mary, and thank you, Dustin, for leading this conversation. This was very insightful, and we will forward any questions and feedback that we received in the chat. We will send on to you, Mary, as well.
Okay, thank you.
Thank you.
Have a great day, everybody.
Thank you, everyone.